Hello, everyone. Thanks for joining us. I'm Dr. Karol Watson. I'm a cardiologist at UCLA, and I'm so pleased to be joined by my good friend, Steve Nissen, who is the principal investigator of the ALPACAR study. He's going to tell us a little bit about that study, and we're going to delve into what it means. Steve, what did you find?
Well, the key here to understand is that there are now a series of nucleic acid-based therapeutics for treatment of lipoprotein A. The drug we studied here is known as zerlasiran. It's a small interfering RNA that targets lipoprotein A. And we knew from phase 1 that it could lower lipoprotein A, but in phase 2, which is what this trial was, our focus was to find what is the best dose and dosing interval to go forward with this drug. We studied 5 dose groups. 2 of them were placebo every 16 weeks or placebo every 24 weeks. And then 3 active groups. One group got 450 milligrams every 24 weeks. Another group got 300 milligrams every 16 weeks times 3 doses. And another group got 300 milligrams every 24 weeks times 2 doses. And the goal here was to really determine how to go forward with this drug in phase 3. What we found in this 180 patient trial is that all 3 dose groups did pretty well. After administration of the drug in either 300 or 450 milligrams, serum levels plummeted, reaching naters of excess of 95% reduction in lipoprotein A. And then, depending on the dose and the dose group, they gradually rose again, and then the drug would be administered again. So you have a peak and a trough effect. What actually happened is that all 3 dose groups for the primary endpoint, which was time average reduction in lipoprotein A, had between an 80 and 85% reduction out to 36 weeks. We also followed these patients out to 60 weeks. And one of the things about particularly the small interfering RNA therapeutics is they're very durable. The effect is long-lasting. And so there were still, quite substantial reductions out at 60 weeks. So there's a long tail of efficacy. Bottom line, 3 dose groups all produced good reductions, different amount of up and down effect. We thought this is the first trial where we've actually looked at time average reduction. Every other trial to date has actually looked at either peak reduction or reduction at a fixed time point. We thought this was a more important way to look at the efficacy because it tells us for patients over time, what can we expect to accomplish with the drug? Now, obviously, lipoprotein A is an important target. And I know you know a lot about this. And
we have so many therapies right now that are being tested.
That's right. And look, the way I look at this is we've got multiple shots on goal. We just hope that one of them ends up in the back of the net. We have an antisense oligonucleotide. We have several small interfering RNAs. We have an oral drug that disrupts the association of the lipoprotein A particles. But we've got a problem, is most of the people that have this disorder don't know they have it. And that's a battle we're going to have to wage.
Yeah. We're all very eagerly waiting the outcome studies.
Yeah.
That's going to make a huge difference, I believe. But you're absolutely right. You can't know what to treat if you don't measure it or how to treat it. So we have to get better at that.
We do. And, I did a study in 49,000 people in almost every country in the world who had ASCVD. And the question we asked was, what fraction of them had had a lipoprotein A level obtained by their physician? and it was 13.9%.
Yeah, and that's even crazier to me because even if you don't want to argue for universal screening, there are certain high-risk groups that you have to argue for screening, and ASCVD patients would be one.
So, Karol, I have a Friday clinic where I'm now seeing mostly patients with elevated lipoprotein A, and they come in and I get a story probably almost every week, something like this. I learned about lipoprotein A on the internet or from the Family Heart Foundation or for some organization. And I went to my primary care physician and I asked to have it tested. And my primary care physician said that they wouldn't test me because they said there's nothing you can do about it. And so they went out to a laboratory and they got it tested on their own. And they had levels that were sky high. And they're typically patients that have terrible family history of disease.
I was going to say, the story I always hear is I had never heard of Lp(a), but my dad had a heart attack at 50, and I got mine tested, and it was
now
high.
I found out I'm high. And what I tell them is, what I tell people, and I tell colleagues, is that knowledge is power. And that it's not true that there's nothing you can do. And as you, I'm sure, do in your own practice, you can take every other risk factor off the table, get their LDL down very low, make sure their blood pressure is controlled, treat obesity if they are overweight, and people will do pretty well, you know. And what I'm trying to do is keep these people safe until we can get these therapies that we're working on the market, developed and available.
Well, that's exactly right. And we do know many risk-reducing strategies. LDL reduction, blood pressure reductions, smoking cessation, so we can absolutely double down on those.
Yeah. You know, I would have never guessed that we'd be in this era of medicine. You know, most of my career was what we would call the era of small molecule medicine, where, you know, you test a whole bunch of drugs, you find something, it does something you sort of like, maybe you test it, a lot of them end up with adverse effects and they never go forward. These therapies, these nucleic acid-based therapies, are very targeted.
May I ask you, speaking of adverse effects, in the ALPACAR study, did you find any significant adverse
There was
effects?
like just almost nothing. You know, the most common effect was injection site reactions in about 10% of people, up to 10% of people. They were mild, they were transient. There really isn't anything, because what these drugs do is they interrupt messenger RNA for just one target. And so they're very narrowly focused, and that narrow focus is a huge advantage. And I think that we're going to now enter an era of medicine. We're going to see more and more of these therapies, antisense oligonucleotides, small interfering RNAs, directed at interrupting messenger RNA for targets that we really want to eliminate. And I think they're going to work.
Exciting time.
But I'm anxious to get these trials over the goal line.
We'll never know until we see the data.
Indeed.
Thanks so much for this. This is a really exciting time, I agree with you, and a really important target. We need to get more people to test and measure Lp(a), and we need to get the word out. A lot of people don't even know what it is.
Absolutely. And thank you for listening.